All right, I'm Josh Gross. I'm one of the third-year ER residents. Today, I'm going to be talking about ocular ultrasounds as part of the resident ultrasound education series. So first, we're going to identify normal anatomy, then we're going to identify some common pathologies we see in the ED. Our probe selection is going to be the linear probe on ocular settings. This has a thermal index of less than 0.3 and a mechanical index of less than 1. You can use an endocavitary probe because it's such high frequency, but it's more difficult to hold and more difficult to find in the ED. So I would stick with the linear probe. Indications for ultrasound are trauma, acute eye pain, acute vision change or vision loss, and concern for foreign bodies or increased intracranial pressure. So contraindications are an open globe. If you have an open globe, just go ahead and call an ophthalmologist. If you think there may be an open globe, make sure that you're using a lot of gel and applying as little pressure as you can to the eye during the exam. So first, you want the patient to be sitting supine 45 degrees with a closed eyelid. Use a lot of gel. You can apply a tegaderm first. Just make sure that you're getting the air out from underneath the tegaderm. Stabilize your fifth digit on the patient's nose or on their zygomatic arch. Nose for the right eye and zygomatic arch for the left eye. Next, you're going to want to adjust the depth and the gain so that you're looking at an anechoic eye initially. You're going to want to get views in the transverse and longitudinal directions, and you're going to want to fan to the left and right and up and down. Then you're going to get a dynamic exam where the patient moves their eye up and down and left and right. Then you're going to increase the gain and do both of those things again. That'll really show all of the possible pathologies. So, normal anatomy, you've got your cornea, your pupil, your iris, your lens, your anterior chamber, your posterior chamber with your vitreous humor, your retina, and your optic nerve. Let's talk about a retinal detachment. So this is an ocular emergency. These patients present with painless visual field loss, flashes, floaters, maybe a curtain vision loss. And this is where that sensory retina detaches from the pigmented epithelium, and it leads to blood loss to the rods and cones. So this is what it looks like. Shout out to POCUS 101. They've got great information on their website if you want to read a little bit more. What you're looking for here in a retinal detachment is this attached optic nerve with this membrane separating off here. It's the attachment here that separates it from a posterior vitreous detachment, and the membrane itself will also be thicker typically. So a posterior vitreous detachment, that's a separation of the vitreous body from the retina. This will typically be in myopic elderly patients. They'll present with fluctuating vision changes. So when they look in a particular direction, they get those flashes and floaters, and then when they look back, those go away. This is what it'll look like on ultrasound. So you can see here, you've got a thin membrane that does not attach to that sheath, and you can see it drawn out over here. An important point here is that if you do see it attach to the sheath, that is a retinal detachment. If it does not attach to the sheath, it could still be a retinal detachment. So it will rule it in, but it will not rule it out. Next is a vitreous hemorrhage. This is when you get blood within or around the vitreous humor. These are typically going to be diabetic patients who present with sudden painless vision loss, cobweb floaters that are worse in the morning, and it can occur with posterior vitreous detachments. And what you're looking for here is this washing machine sign. So this is what it looks like on ultrasound. And you may need to increase the gain and ask the patient to move their eye to really get a good view of that washing machine sign. Next is a central retinal artery occlusion, or a CRAO. This will typically be a diabetic patient with hypertension, hyperlipidemia, AFib. They'll come in with sudden painless monocular vision loss. This is also an ocular emergency because the CRA essentially travels with the optic nerve and supplies the retina with blood. So if it is occluded with an embolism, it's equivalent to a stroke, and it is something that you should call a consultant about fairly quickly. This is what it looks like on ultrasound. Let me go ahead and hit play here. So what you're going to do is you're going to get a good view of the eye, put a Doppler over the posterior chamber, and get that nerve sheath in view. And what you'll see is a lack of arterial flow. And this is a normal eye. It's very quick, very easy to do, and gives you a lot of information. So certainly worth trying if you're concerned for CRAO. Next is foreign bodies. So this will be a painful foreign body sensation in the eye with vision changes. It can be dangerous because it can lead to globe rupture, infection, toxicity, and vision loss. And this is also an ocular emergency. So pretty obvious here. You probably wouldn't need an ultrasound to see it, but it can be a lot more subtle as well. So you can have no signs of damage to the outer portion of the eye in that anterior chamber, and then you put an ultrasound on and you'll see this hyperechoic structure with this hypoechoic shadow behind it. So pretty obvious on ultrasound and can really change disposition. So it's very helpful. Ruptured globe. So ruptured globe is a full thickness disruption of the sclera or cornea resulting from blunt or penetrating trauma. Typically these patients will have painful vision changes, teardrop pupils, extrusion of intraocular contents, hemorrhagic chemosis, and a positive Seidel sign. Obviously an ocular emergency. And what you're really looking for here is buckling of the sclera and decreased globe size. So this entire globe will be decompressed and you'll see this buckling. So let's take a look. It is not very subtle on ultrasound. Okay. Lens dislocation. This can occur in traumas or in patients who have Marfan's. You can get a partial or a subluxation or a complete dislocation. These patients will present with vision changes and a normal pupillary response. And this is also not very subtle on ultrasound. You can see the lens just floating down into this posterior chamber. You can expect it to move when the patient moves their eye left and right. You'll see that lens move around with them. Next is a retrobulbar hemorrhage. This is blood in that retrobulbar space, usually from trauma, but it can be post-operative as well. These patients will present with sudden onset pain, limited extraocular movements, proptosis, and an afferent pupillary defect. This is also an ocular emergency. And what you're looking for is this guitar pick sign. So the globe itself will kind of have this triangular view to it, and you'll see blood in this region right around the nerve sheath, and it'll be hypoechoic typically. So this is what it looks like on ultrasound. Oops. Okay. And last, we'll talk about elevated intracranial pressure. So ultrasound can be very helpful in differentiating the chronicity of elevated intracranial pressures. So if you are concerned, the first thing that you're going to want to do is get a static view of the eye, freeze the screen. You're going to want to look at this part right in here where that optic nerve sheath attaches to the retina. You're going to want to measure 3 millimeters back and right across here from the outermost lateral borders of the sheath from one side to the other. What you're looking for there is a measurement of less than 5 millimeters. Think of a 3x5 index card. You want to measure 3 millimeters back, and normal is 5 millimeters. So if they're above 5 millimeters, that means that they've got signs of elevated intracranial pressure. Papilledema specifically occurs when you've got signs of elevated pressure, and then you've also got optic disc edema, and that typically occurs with chronic elevations in intracranial pressure. So this is what that'll look like. So as you can see, a patient with pseudotumor, chronic elevated intracranial pressures, they'll have that optic disc elevation here, and a patient coming in with intracranial hemorrhage will have an increased nerve sheath diameter, but they will not have the optic disc elevation that you would see in chronic elevated intracranial pressure. So I think that just about finishes it. These are my resources and my references. POCUS 101 is at the top there. It's really, really helpful for everything ultrasound, but particularly ocular ultrasounds. Feel free to email me if you have any questions. Thanks for watching.